Welcome to the World Institute of Critical Care and Emergency Medicine, a non-profit educational organization built by physicians for physicians with a mission to improve global healthcare. Our goal is simple: to help healthcare professionals around the world make informed decisions, enhance critical thinking, and excel under pressure, especially in high stakes, critical, and emergency situations. WICCEM offers comprehensive training and resources in critical care and emergency medicine, featuring a core curriculum that covers adult and pediatric care, with courses in pulmonary.
Okay, hello everybody. It's my pleasure to be with you today. I'm Khaled Swaifi. I'm going to really introduce the chairperson. We have Wafa and we have Mireille. Go on, Wafa. Start, please.
Hi, I have to welcome our star, Dr. Khalid Suwaifi, consultant intensivist, and he is the head of the ICU department. He is also in the World Institute of Critical Care and Emergency Medicine. He is from the American College of Chest Physicians. He works in Saudi Arabia. Dr. Khalid have initiated a lot of nice programs, ACCN, in nephrology, the fellowship, which we are here with Dr. Amr about the critical care, and now the new baby, the weight obesity medicine fellowship, which Dr. Khalid thankfully will take us in a tour in it. So let's rock the stars with Dr. Khalid. Yalla, it's you. The floor is yours, Doctori.
Thanks, Wafa. So over the past 25 years, my colleague and I learned a very important lesson that you should not stuck with the weight you have. You can always make it better. Your health can be better. Your metabolic pathway will be better. You'll be away from all chronic diseases. That's why we start really to initiate a fellowship in the weight management and obesity medicine. A lot of people asking me what's the relation between the obesity and critical care. I'm always telling that obesity itself will increase the morbidity and mortality inside intensive care by around 15%. So it's very, very, very important really to take care of your weight, to live healthy, not only for yourself, but for you and your generations of you. So the beauty about the obesity fellowship that it is actually have two flavors. The first flavor is about weight management. So we are going to learn every single strategy regarding weight management, protocols, guidelines, lifestyle modification, dietary changes, and also we'll learn a lot of science about obesity medicine. You can learn about the diagnosis, treatment, and prevention of obesity, what kind of medication you are going to use, when to refer to surgery, and when to also implement metabolic testing, both for adult and pediatrics as well, because we will see together the syllabus. We'll talk about the adolescent obesity and woman obesity as well. So weight management and the obesity medicine fellowship is very rich syllabus, and the detailed program will have two modules, each module over 17 weeks, 3 chapters, each chapter with 4 main topics. Each topic runs for around 1 week and followed by case presentation and discussion. Module 1 will have a 3 mini module. The first mini module about fundamentals of obesity, introduction, body composition assessment, genetics and obesity, metabolic syndrome and insulin resistance. Then you go for nutrition science. We will speak about nutrition management, evidence-based dietary approaches, the role of complementary medicine, food psychology, and eating disorders. Then we'll go through lifestyle modification with 3 also weeks about exercise and obesity, novel therapeutic targets, and precision medicine in relation to obesity. As I mentioned, after each mini module, we'll have a virtual workshop webinar. Then in module 2, we'll talk about therapeutic approaches, different therapeutic approaches. The intervention, 4 lectures, pharmacotherapy, GLP-1, bariatric surgery, a kind of bariatric surgery which is the best for best patient, bariatric nutrition, special population also, around 3 lectures about childhood and geriatric and woman obesity, maternal obesity as well. The advanced module, about 3 lectures about targeting mind, weight maintenance, complication, and the latest guidelines. Timetable is here. We were going to talk about it in the introductory lecture before. And crystal clear that weight management and obesity medicine fellowship is very beneficial and very unique. And you don't know that nothing really all over the world like that. Also accredited by the American Association of Academy with around 64 hours. Timing will start toward end of March 2026, and we'll have 2 entries, one end of March and one end of August, to allow people also with critical care nutrition to apply for end of August fellowship. So if you are really concerned about your health, your weight, stay with us. Register with us. Is the cost around $600 per module, 1,000 per the whole fellowship if you are going to pay both module together. And the fellowship landing page is there. If you go to the chat box, you'll find the registration link as well as the fellowship landing page. I'm very happy to introduce really my partners. We have Mireille, we have Wafa, the directors of the fellowship. We have Mona, the coordinator of the fellowship. And I am Khaled Sweifi, and I hope the webinar will be of value for all of you. The best time to plant a tree, always we are telling the Chinese, telling the best time to plant a tree was 20 years ago, but the second best time is now. So let us to shape our future. Thank you very much.
Thank you so much, Dr. Khalid. Are you going to go through the fellowship modules now, or Dr. Mireille will go take over to introduce our guest speaker?
The timetable, you mean, like that?
Yeah.
It is actually is not now, because we can make it for the
Later
second webinar, because it will be so much for the people.
Okay. So the floor will be for Mireille to introduce
Yes.
Sweet Mona. Dr. Mireille, Professor Mireille, of course, she is one of the elites in this field that I am honored to introduce her, to introduce our colleague and friend Mona. Nice to see you, Mireille, always, Habibti.
Thank you, Wafa. Wherever you are, it's always fun for me to be there. And Dr. Khalid, thank you for having me, Dr. Amir. And with no further ado, I would love to introduce Mona Jamal. She's a clinical dietitian with an experience of 15 years. Currently, she's the lead dietitian in MediClinic Middle East, and she's a certified for obesity management by World Obesity Federations. She holds a master's in business and health management. With no further ado, Mona, please start your lecture. We want to learn from you and latest updates.
Good evening, everybody. Thank you so much, Mireille, for the introduction. Thank you so much, Dr. Khalid, Dr. Wafa, Dr. Amir, also for sharing this beautiful platform. It's a great honor to be among all of you today. And indeed, let us start talking today about a beautiful talk, specifically that now we are living, in a very innovative era, which is the obesity medicine. And now we have a lot of, evolving classifications and definitions and diagnostic tools, a lot of, pharmacotherapy involved, a lot of, procedures and endoscopic opinions, and a lot of, multidisciplinary approach around obesity. But before talking about classification, medication, intervention, there is something called perception. And that's why today I wanted to start, this platform with talking about the unconscious bias in obesity care, how we as providers, we are perceiving obesity, And, because how do we see a patient with obesity can shape, the questions we ask, the assumptions that we're making, the urgency we're feeling, and the empathy we are offering. We as providers, we always want to provide the best care for the patient, but talking about a very sensitive topic, we can easily make a harm for the patient, maybe with the way how we're looking at the patient with obesity, maybe with like a small sentence that we're offering. So that's why today we're going to tackle, those aspects. And I do believe that, the physiological layer is something that is rarely taught, but I would definitely believe that awareness is the first clinical intervention specifically with such of a sensitive topic. So let me start my presentation. So this is a picture that is showing two beautiful ladies. The first one is a housewife living, a loving mother and loves cooking. And the second lady is an entrepreneur. She's a career driven and she likes adventure. For many of us, this picture sounds to be not assigned with each description. And this is simply because our brain is wired in a way thinking that obesity is always related to limitation, to people with less discipline, people with less achievement, less control, and less success. And people, with a healthy body image figure is more associated with competence, achievement, and empowerment. And sadly, these are just beliefs and they are not facts. And as we've said, this is simply because the brain is wired to use these shortcuts. And in the psychology, this is called the implicit bias. So let's say that these assumptions automatically happens on an everyday life. So how we can magically disappear these when it comes to our clinic. So at the end, we as providers, we are humans, and also our judgment, our intervention, our care is also based on these beliefs and filters and memories that we've been always exposed to. And this can definitely influence how seriously we take into consideration patients with obesity, how much time we spend in the clinic with those patients, and how much responsibility we place on the patient versus the disease. So weight bias refers to a negative attitude and stereotype about obesity of people living with obesity, the judgment and the person's values, skills, abilities, or personality based on the body weight or the body shape. We have different type of weight bias. We have the social weight bias, we have the academic weight bias, we have the employment weight bias, the media, and finally we have the health provider weight bias that we're going to tackle today. So when it comes to weight bias, it doesn't know gender, it doesn't know age, it doesn't know ethnicity, it doesn't know socioeconomic status. So weight bias is related to all of these aspects. So this is a study that was done in 2015 and it's mainly targeted to the youth population. And they were asked about what would be the major reasons for bullying. And as we can see, there is a significant, response. The highest percentage came to be around body weight. And all of these respond were regardless the nationality. So this study was done in the USA and Canada and Iceland and in Australia. And all of the high scores were scored around body weight. And also another study that where parents were asked, what do you think your kids could be bullied for? And as well, being overweight or having a weight issue was scored as the highest, aspect among the other, reasons for bullying. So when it comes to the healthcare providers, depending on the studies, 69% of the patients, adult patients with obesity, reported being stigmatized by healthcare providers. 1 in 3 doctors feels that he's uncomfortable in treating patients with obesity. Patients experienced weight stigma are 3 times more to cancel their appointments. And we as providers, we spend less time in the consultation, around 27% less time for the cases with obesity. And there is less, cancer screening and pelvic examination specifically for female suffering from obesity. So as we can see that the care is definitely negatively influenced for patients suffering from obesity. Weight stigma increases mortality independently of the body mass index. So what are the consequences of weight bias? So the consequences are on many ways, including the healthcare quality. So as we've mentioned, patients, they will start to cancel, they will start to avoid, they will reduce, their adherence when it comes to seeing the doctors. And this that can definitely implement negatively on the clinical outcome, like with poor glycemic index, less effectiveness with managing the chronic disease. And also this can lead to a lot of, psychological distress like depression, anxiety, low self-esteem. Also, there is a higher, reactivity for the cortisol, for the CRP. And finally, this can amplify further the negative eating habits and the distorted eating habits like eating secretly, binge eating, maladaptive weight control, and definitely being more demotivated to exercise and to have less motivation for a physical exercise. So what are the reasons to have this weight bias? We have an explicit bias, which is we think that people with obesity simply they have a lack of willpower. There is the implicit bias, which is the unconscious bias that comes without thinking. So that usually comes from repeated exposure, from the social media, from the filters, that we have in our brains. And finally, it could be related to lack of knowledge. So we didn't have the training for obesity, or maybe the policies that we have are not in place, or maybe the setup in the clinic is not also suitable, to manage the patients with obesity. Again, I'm going to share with you a paper that was published in 2014 to show the impact of the social media or the media on increasing the stress for the weight stigmatization. So we've had two groups, two female suffering from obesity. The first group, they were just shown a video of a neutral and natural exposure. And the second group was showed a video that included negative eating behaviors. And as a result, the group that was shown the second video, they ate 3 times more compared to the first group. So this is just to show again how the media can also impact negatively weight stigma and eating behaviors, and also the cortisol reactivity was much higher. Unfortunately, every time when we want to describe a patient with obesity, we see this famous picture. A patient is lying on the couch, watching TV, so showing sedentary lifestyle and holding unhealthy food options. But we never show that also those patients are making a real effort in maybe trying to be more active, picking healthy, for example, food options. So also this is just to worsen the public attitude around patients suffering from obesity. So this is a survey that was done in my hospital to understand, how doctors, they are perceiving, obesity. So this is a paper that is not yet published. So we've sent a survey for all the doctors, and unfortunately, we've got only 63 responders. The responders were mainly surgeon, anesthesiologist, primary care, intensivist, endocrinologist, and dietitians. 60% of the participants mentioned that they felt comfortable while addressing obesity. 34% mentioned that they've had specific courses in obesity, and 48% wanted to learn more about the obesity medicine. 25% of the doctors or the HCPs mentioned that they see a lot of cases of obesity. More than 50% of their patients are suffering from obesity, and the opinions around obesity were different. Some of them thought that it was related to a lack of motivation, or maybe patients didn't have knowledge about food, or it could be related to a genetic predisposition. But again, you know, the root cause of obesity are much more complicated and much more branched. This is a picture that is taken from the World Obesity Federation, showing that obesity is not only eating and exercising. There is a big chunk related to genetic. 40 to 70% of obesity is related to a genetic predisposition. Stigma is also, you know, one of the cause of obesity on top of many other factors. So what do we need to do as providers? We need to use the power, or we need to use the patient's first language. What does it mean? So the patient first language puts the person before the disease, acknowledging their identity, and then the condition that they live with. So the condition that they're living with is obesity, which is a chronic complex disease that is not related only to a personal failing. So this will reduce the shame, the defensiveness, the avoidance of care. It will definitely improve the engagement, the trust, and the treatment adherence. It will demonstrate a lot of respect and empathy, and also it will be aligned with all the international guidelines that are also, related to obesity. So usually we need to avoid using the terms like obese or morbidly obese, you are fat or overweight, you need more willpower, you are not compliant, you are not motivated, you just need to eat less and to exercise more, because all of these are tones of blaming. And we need more to use person living with obesity. Obesity is influenced by metabolic, hormonal, genetic, sleep, and stress. And let's make a plan together that fits your journey. So what are the barriers, you know, to discuss or to open a discussion about obesity? As we've said, the providers could be concerned about offending the patient. It could be the lack of confidence, or it could be simply the lack of awareness about obesity, modalities, treatment. And sometimes while managing obesity, we use a lot of complicated terms that are easy for us, but may be very complex to the patient. So instead maybe of using obesity, we can tell them that this is an excess of fat or extra weight in the body. While taking the waist circumference, a lot of the patients will feel offended. Why you're taking the waist circumference? So we need to tell them that the waist circumference is like an alternative way to understand your risk factor to develop disease. And when it comes to the clinical conversation, when you want to talk about weight, it's always, you know, a better way to mention to the patient that your weight is affecting your health. So let us always turn the conversation around improving the health, not about losing the weight, and also to educate the patient that obesity is not your fault, but it's a condition that is related to many factors. It's a chronic disease. When it comes to the patient or to the treatment adherence, instead of saying you're not compliant, we can say that it seems that the plan was not easy to follow. Let's adjust it, let's tweak it to find a better way. Instead of telling the patient, you need to lose 20 kilos, let's talk about losing 5 to 10% will improve your general health, including sugar, blood pressure, energy level, and let's take it step by step. And also let's make sure that the equipment that we have in our facilities are also convenient for the patients. The Canadian Obesity Guidelines do emphasize on the person-first language and actively address weight bias. Again, clinicians should use inclusive communication that elicit individual preferences while addressing potential barriers to the care. So these are the 5 A's that were mentioned or adapted from the obesity of the Canadian Association. As we can see that the first A of the obesity management is asking permission. So again, this is to reflect on being and using, you know, an empathy while, you know, treating those patients We cannot directly jump, and tell the patient we need to lose weight. We always need to ask permission. Is it, a suitable time for you to discuss about your weight? And this can definitely improve the relation, building the rapport, and also, the continuity of the care. Later on, we will jump to the assessment, to the agreement of the treatment, and to the modalities used. We've mentioned earlier as well that the clinic or the setup, the hospital needs to be well equipped for the patient. We need to make sure that we have adapted scales, we have appropriate size blood pressure cuff, we have good gowns for the patient, and also the posters that are around in the hospital needs to be less shaming and less defensive. And also, if the electronic system could be supportive in creating maybe alarms or referral pathways for the dietitian, for the endocrinologist, also this could be considered as a good aspect. This is how my hospital looks like. So we are a hospital that is certified as a center of excellence for managing obesity. As you can see in the waiting area, there is a specific chair that fits patients with a large size. Also in the clinic, in the consultation room, the chairs is also affordable. A lot of my patients, they ask, why do you have this size? So I tell them this is a business class seat and this is a regular seat. So which one would you prefer? And this is how we can turn, the conversation more into fun. And this is how the patient will start accepting, those equipments. So I will reach till the end of my presentation. Also for us as providers, there is a specific image bank that we can use in our presentation or even for the public that doesn't show a lot of offending images for the patient suffering from obesity. So finally, as a conclusion, let us make sure that weight bias in healthcare, we are human beings, exists. We need to acknowledge and we need to recognize that this bias exists in healthcare settings. Let us all adopt to use the patient's first language. It will become more respectful, less judgmental, and it will enhance the communication and the continuity of care. Let us also, make sure that we have all the setup, all the equipments, all the tools needed for the patient. And finally, we as providers, we can lead the change. Obesity courses or maybe digging further into obesity or a fellowship would be considered as the best platform to make this change happen in a good way. I hope I didn't take a lot of time. These are my references and thank you so much.
Mona, this was a very lovely lecture. I think you touched upon very important things, and it is about time we open the discussion on these topics because people come in all shapes and forms, and they need to be respected, specifically nowadays that we have the idea of sarcopenic obesity or metabolically healthy obese. So not everyone who has the right BMI is healthy, and not everyone that doesn't have the right BMI is unhealthy. So I think we're moving away from weight to body composition, and you come and touch upon the right aspects. And I appreciate that you chose this topic because it's a sensitive topic and everybody has to talk about it, especially nowadays when we talk about GLP-1s. And I hear a lot of people saying that maybe you're choosing the easy way out, knowing that it is a physiological disease. A lot of times people think that obesity is a choice. Sometimes it is, not every time it is. So, like you're touching upon this beautiful aspect and a good eye opener. And I'm grateful that you discussed this.
And can I add something? Also, I love something about Mona when she spoke about, if you see that she touched the psychology of the patients, the way how she approached them with the chairs, how she can tell them first class, business class thing, how the doors to open, the windows to enter to the patients. Mona, it's really nice. I enjoyed every minute I've listened to you because this is really something that not everybody knows. No wonder you have the excellency of obesity in your center because you're touching a lot of things that not everybody knows how to work
Tackle.
on psychology, the comfort zone for the patients to feel free to approach to you. That's an amazing thing, you know. And all the things that you have said, I agree totally with Mireille. You have opened really, let's say, a line that really open eyes on for every. I hope we have a lot of physicians with us, so because they are, we know that, but they have to know that, you know. And I totally enjoy every single word, Muna. Thank you.
And
Thank you.
if I may say something about the Canadian dietetic practice, it is absolutely forbidden to assume that when a patient comes over, even if they are overweight, to even open the topic of weight. So usually how the conversation starts, a registered dietitian asks, what is it that you are here for? What do you want to achieve with the plan with me? And then they will let us know. Even if weight, you see that maybe visually weight is an issue, if the patient doesn't express that weight is an issue, the dietitians are not allowed to open the topic until the patient allows themselves or allows the healthcare professional to open that topic. So, and that way I see patients who are overweight and I've never asked, like weight is
Same.
not one of the questions I ask first.
Same,
You know,
same.
it is they explain what they need, and then those are the biomarkers that I would discuss according to what they need to treat.
Yeah, exactly.
If they open weight, great, I will open the discussion. You know, so and I'm glad that you're opening this topic. Weight bias is an issue. And one last thing, if healthcare professionals do not empower these patients will feel overlooked and disregarded. And if you don't believe in yourself, you don't invest in yourself. And us as healthcare professionals, we have a role to empower and enable these patients and tell them you are seen, you are important, you are worth to invest in yourself, whatever it is. So
That's
thank you,
why this fellowship, ya Mireille, which Dr. Khaled and
Khalid.
Umar are doing, will help a lot in opening the sites for the doctors, the dietitians, everyone to have the role, especially when you spoke about GLP and GIP. When you talk about GLP and GIP, I see a lot in my clinic that they lost muscles, not fat, because they are not following the right directions for for the pattern of exercise and dietary pattern properly that meets with the GLP and GIP. So I encourage people to be with us in this fellowship because it will take them to a tour into how to manage obesity correctly, from
And safely.
physiology to medication and exercise. So it's going to be a nice tour, refreshing, encouraging. You will have the right track. And with the good start with Muna about the bias, I think the floor is now ready for them to go with us in this tour. What do you think, Khaled?
Yeah, I agree 100%. Great. Thank you very much.
You know, they say in medicine, first do no harm. Causing this bias is a part of harm. So maybe with the fellowship, we can remember not to harm our patients.
Yes.
No, can we go for the questions? I'll take one and you'll take one.
I don't see any.
There is
Okay,
one
yes.
question from Bilal talking about hypothyroidism patients. Yamuna, are usually obese and whether GLP-1 therapy will be beneficial for these patients, being GLP may also cause hypothyroiditis and the thyroid cancer. And what do you recommend of these suffering from obesity?
Thank you, Bilal, for this question. So hypothyroidism is not a contraindication for GLP-1, therapy. Again, before starting, any of, the GLP agonist medication, the patient needs to be properly assessed by a physician, to see if the patient fits, the criteria for inclusion and to check the exclusion criteria. and also to assess, apart from the medical aspect, to assess the readiness for the patient, to go through this journey, without forgetting that the patient, on top of taking those medication, needs to be thoroughly, followed by a dietitian, just to manage, his lifestyle changes. Let's keep in mind that the GLP-1 medication, they're unfortunately not this magical ones. And, the pillars every time for managing obesity start with a good lifestyle changes, an exercise regimen, a lot of, behavioral therapy on top of the medication. And do you recommend for these patients suffering from obesity? So again, the indication needs to be always checked by a physician. And if they do fit, the criteria, definitely GLP-1 are, one of the good, ways, to manage obesity. Absolutely.
Dr. Mire, will you take that second question, please? I think it's for Dr.
I've been answering those. There's one more. Is use of Ivanotrem helpful after using GLP-1 medication? This is for Muna. Or
There is another one about the curriculum down. I think if you go down, I saw something for Dr. Khalid, I think. One second,
for the discounts, I answered, yes.
Yes.
Yeah.
You answered that, right? Yeah, okay. Is there Evatorium was helpful after using GLP? This is a medication in
Suppresses appetite.
It's in Egypt, yeah, Muna. Do you know it?
So honestly, I'm not
Okay.
very aware about this medication. If
Herbs.
somebody knows about it,
I know it. It's from Eva. It's in Egypt. Dr. Khalid, I think you know it, but it is helpful. It's made from herbs after to maintain, I mean, the weight that it have been reduced. Actually, they even use it for weight reduction, but it have to be with exercise but with GLP-1 after that to maintain. Of course, after the proper weaning from GLP, GIP, then you can use such a medication to sustain and help you with the diet and exercise. Yes, Sayed, you can.
Muna, somebody's asking, when somebody's working all day long, but they face obesity, what could be the reason?
Again, as we've showed earlier, the reasons for obesity are, multi-branched. So as we've mentioned, there is up to 40 to 70% of obesity is considered based on a genetic predisposition. Definitely, there is a part related to lifestyle. It could be inappropriate eating habits. It could be, the sedentary lifestyle. Let us not forget that sleep, stress as well could be contributing. Multiple pregnancies, psychological, as we've mentioned, the mental health. Some medication also could be triggering. So we need, to go through like a thorough assessment to see what is contributing. I myself am a dietitian, so majorly I will be focusing on the eating habits, and on the lifestyle of the patient. Definitely, I would recommend, referring the patient to a physician to run, a medical assessment, a blood test to see if there is any other, underlying medical condition that is contributing. And if we see that the lifestyle, the eating habits are not the best, we will put a plan together with the patient to support him to go through a healthier lifestyle, to create a little bit of caloric deficit, to induce a longer satiety, and to make sure that the nutrient adequacy of the patient is fulfilled. And definitely we have a role in also monitoring the body composition to make sure that we are not, or we are supporting the muscle mass, and mainly the weight loss happens from the fat mass, as earlier Dr. Wafa mentioned.
I saw that Dr. Mire is answering one, but there is one about pregnancy safe after bariatric surgery, and what are the long-term nutrient supplements that can be used? definitely for bariatric, he meant. After bariatric, you will need support. So in pregnancy, is it safe? And what
So
supplements?
yes, so usually we need 12 months, after a bariatric surgery to fall or to think about pregnancy. We need to make sure that after a bariatric surgery, the supplementation and multivitamins is also, taken into consideration just to make sure that, a nutrient deficiency will not be impacting the pregnancy, the fetus, and the mother. And also it depends on the type of the bariatric surgery.
Dr. Mirey?
Dr. Khalid, there's a question for you. Timing of the fellowship sessions, are they flexible, or if one starts at a certain time, they have to finish after a certain time?
There is actually fixed schedule, but the materials is present all over the two setting time. So the material is recorded. They can really go online and fix it in a proper time. But the time is flexible, very flexible. But he has to go in a specific time and finish in a specific time.
Okay.
Usually, how long do they have to finish a module?
The module usually taking 16 weeks, and each module taking 16 weeks. So two
Yeah.
modules, so 32 weeks.
Again, for Muna, and Dr. Khalid, you will let us know how many questions we still can take time regarding to time.
We have 1, 2, 3, 4,
Okay.
actually.
I believe
Yeah.
you can take a question after my the timing. Somebody want to leave early.
Then let's do that. Yes, because I know that we're delaying you. Yes. Okay.
There is one question from Amina. Can depression medication can cause weight gain and hormonal imbalance, especially in women? And what can be done in such women who can't stop medication but also gain weight easily? So we can have a couple of questions, Dr. Mirey?
Yes.
Yeah.
Yes.
Muna, you are
Instead of
ready.
typing. Muna, there's one question that says, what appropriate course period we can start Manjaro for a new lady, first time in use of Manjaro, in 3 months course? Is 3 months course enough? Then wean on Evanotrim. I think I want to say a disclaimer before Muna speaks. Muna is a clinical dietitian. All of these, and Muna already said this, that this has to be in conjunction, in parallel with the medical doctor. A lot of these questions, even if we as dietitians can have an opinion, it has to be in collaboration with a physician who's specialized with these medications.
Evanotrim, Dr. Mirey, is more into herbs that's usually prescribed from the dietitians in Egypt. That's why it's very popular. It's a very
I'm
nice
with you, but
medication.
Manjaro weaning.
But Manjaro is,
Yes.
yeah, now we can see
Yes.
your screen, doctor.
Okay, so may I start?
Yes, please.
Okay, thank you very much for everybody. Thanks for attending. So again, we are going to talk about weight management. Thanks, Mona, really for your nice presentation. I enjoyed a lot and I learned a lot also from it. So now we're talking about different aspects. We talk about lifestyle issues, nutrition, but now we are going to talk about really the kind of fasting. Everybody knows about intermittent fasting, 16-8, 5-2, like that. We know also about alternate day fasting. We know also about like a short-term fasting, but nobody knows about metabolic microfast. And metabolic microfast is the kind of fasting which is going to teach our body how to be metabolically flexible. This is really missing. So if we are metabolically flexible, we are in a good shape and we can really heal our insulin resistance. So everybody is dreaming by fountain of youth, but it's not that easy. It is it's very challenging. But really, if you focus and really change your lifestyle and you know the role of the game, you can really make it better. The most important challenges in the weight management is broken metabolism, because toxins are present everywhere in our food. If you're going to eat apple, for example, or kind of fruits, you will find calcium bromide, waxin DBA. These kind of materials are used in like explosion of like bombs. Aluminium foil is toxic. Water pipes is toxic. Aluminum is related to multiple sclerosis. Pesticide, herbicides is very toxic. Sulfate present in shampoo and like that can cause hair loss. Carbon and lead in smoke inhalation, eating lately outside, shawarma, all like this expose you to carbon monoxide poisoning. So also radiation is present everywhere, and we have some sort of EMF coming from our mobile phone and our Wi-Fi issue. Mercury in dental amalgam and in vaccines also can cause a problem, especially with kind of autism. ADHD, fluoride in toothpaste with hypothyroidism, which is common nowadays, especially in ladies, arsenic in rice, and also lead in kind of vaccine. So mercury has been associated with autism, and aluminum with multiple sclerosis, and all kind of this kind of toxin will slow down the metabolism and can cause really a significant harm to our endocrine glands. That's why we NCEV ATB diagnostic criteria for cardiometabolic syndrome has not been changed since 2005. Central obesity is a central obesity. Waist circumference more than 102, men 88 in women. Elevated triglyceride more than 150, reduced HDL less than 40. Elevated blood pressure more than 130 over 185, and elevated fasting blood sugar over 100. When you go here and you look, you will find really they are concentrating on central kind of obesity, which is really related to the metabolic problem. And if you go to HDL also, is very, very important. I'm always telling that try to look at HDL, try to improve HDL. If your HDL is low, it means that you are really in a serious health trouble. Now they are thinking to add hyperuricemia because uric acid now is a good prognostic factor to metabolic syndrome. So if you are kept on eating dirty food and you think it is as healthy for you, you need to stop that. You are lying to yourself. It is not healthy for you. It is a poison. And this being associated with glycemic variability, and they will end with insulin resistance. It's all catastrophic. Insulin resistance is your destination. Of course, nobody likes his destination to be like that. We don't like to see the worst life package of atherosclerosis, type 2 diabetes, and anxiety, depression, cancer, with very poor quality of life, fat rich, protein poor, insulin resistance, which all is complication, fatigue, constant hunger, sugar craving, inability to lose weight, excess fat storage, abdominal obesity, hormonal imbalance, and high cholesterol and triglyceride. Is it really you? Do you think, is it really you? Are you happy with your shape like that? This is really endless scenarios. People don't lose weight to get healthy, but they get healthy first, then lose weight. This is a very, very important point. If you want to going to leave now, this is the first most important take-home message. Because really, if you remain unhealthy with metabolically broken, it will end with a catastrophe. But nothing in life to be feared, it's only to be understood. So we have to understand the mechanism of obesity well. And as we mentioned, the kind of metabolic problem, hormonal dysregulation, insulin is sky high most of the time, but is resistant, the receptor is not working. Stress hormones is sky high. So whatever, even if the insulin is working, with high cortisol and high stress, still you are storing fat. Estrogen also is a great problem, especially coming from the fat stored in the abdomen. And then you have a low growth hormone, low thyroid, low testosterone, excess calories. All will end with hypometabolism, hyperinsulinemia, and insulin resistance. So if you are going to eat frequently, which is called the frequent meal effect. You will spike your blood sugar, your insulin will be released, will bump the insulin, actually store fat, and ending with insulin resistance. So really is a kind of vicious circle. You cannot really get out of this vicious circle without really stop frequent meal. And this was the rationale behind starting the kind of fasting or hunger. We have been created to have some sort of not eating and some time of eating. So how to become super healthy? I'm always telling that you need to have a strong gut health with a strong microbiome. You need to have the whole body detoxification and the cleansing effect. If you are heavy metal intoxicated, you are not able to detox your system. You need to switch on your metabolism, turn on your metabolism every time, and you need to be metabolically flexible. You need to turn off stress and to adopt healthy lifestyle in the form of to eat healthy diet. You need a period of caloric restriction. You need to exercise regularly and you need to sleep adequately. So intermittent fasting. So what we know about intermittent fasting is like we have a 16 to 18 hours window which we are actually eating or kind of fasting, or alternate day fasting, like called OMAD, eating once one meal a day. And you have to eat time about 6 to 8 hours a day, or alternate day fast as we mentioned. And you end with burning belly fat because you are switching to different fuel now. You're able to tap your fat fuel rather than glucose fuel. And also associated with increased growth hormone significantly, more than 20,000%, immunity increased by 200%, and macrophage function, and also the stem cells regeneration. If you go to that, look at that staircase approach for stepwise approach for the intermittent fasting or the fasting in general, you will find phase one will start between 0 to 12 hours. So at the end of 12 hours, you finish most of the glycogen stores because of the glycogenolysis start to be activated significantly, and you're able to reduce significantly the insulin level. When you go to phase two, between 12 to 16 hours, now is the time to, the glycogen is all depleted, and the time to burn fat because you start to switch on the AMPK pathway. And the AMPK pathway is a kind of a sensor in our body. If you are fasting, you are not eating, you're exercising, if you are stressed, the AMPK pathway start to switch on and start to ask your body to search for different fuel, which is definitely the fat. Then from 16 to 24 hours, this is the time of the body trying to create glucose, because the body is really an excellent to understand what's going on. We don't have glucose in the system, the insulin level is very low, so we start to make some sort of gluconeogenesis. And here people are scaring that you might really start to break down muscles, but really the body likes to break down fat. We have glycerol here coming from fat, can be converted into glucose between 16 to 20 hours. So you don't really care much about your muscle, especially if you're eating high protein in the eating period. Then you go for the extended fasting around 24 hours. So this is the time of having ketosis and the time you to feel really a little bit tired because really of start the body to switch between glucose and fatty acid to ketones. This is called keto flu. And then you go for, if you extend the fasting more than 24 hours, you achieve a 30 hours. This is the time of the maximum autophagy. So if you are going to accompany the fasting with exercise, for example, during any of these phases, you're able to achieve a higher autophagy. And autophagy is self-cleaning of the cells, especially the damaged protein and damaged mitochondria, which is called mitophagy. If you're not able to do that, you stay metabolically broken. So you need really to activate the autophagy all the time. And the best to activate autophagy is to have a hunger and to involve yourself in regular exercise. So advantage of time-restricted feeding or fasting is very clear that reduce incidence of breast cancer, cardiometabolic disease, including diabetes, compared with calorie restriction. Autophagy will be significantly improved and reduce signs of aging and dementia. The reduction of mTOR during the hunger and fasting, which is actually potential inhibitor of autophagy. So if you stop or reduce the mTOR, you're able to activate the autophagy and reduce the is called aging, inflammatory cascade with aging. Also, the time-restricted feeding tend to reduce significantly the total body fat, the visceral fat, and the waist circumference. So we have really confirmed this from meta-analysis in 2024. And the best thing to achieve from fasting is to heal your insulin resistance and to clean unhealthy cells to be away from cancer, autoimmune disease, including the gut health and mood and stabilization. So the claim against prolonged fasting is going to, if you continue, especially more than 30 hours, going to slow down metabolism. And this claim also that fasting with intermittent fasting and like that is happening mostly during sleep time, which is metabolically inactive. You are not eating, which is great, but you are metabolically inactive. We need really to fast during the active time. When I was in my trip to Oman a couple of weeks ago, I was invited just to take a breakfast. I'm usually skipping breakfast, so I have to take a breakfast at 3 o'clock. Oh, let us to eat lunch. And then, so I don't want to eat lunch because I want to enjoy a good dinner. So, but all the day I'm metabolically active. I'm walking and seeing around, going to the beach, whatever. So, if you are going to short time fast during the time, for example, if you eat your breakfast and between breakfast and dinner you did not eat and you are metabolically active, you are actually able to improve your metabolism significantly and to reduce your body fat without really slowing down your metabolism. So also you need to feast. You need to fast and you need to feast. You need to feast. What does mean? You need really to celebrate. You have family, you have friends. You don't like really to not to eat with them, and also you don't like to have a sarcopenia with muscle mass loss if you have a prolonged fasting time. So microfast is a kind of different concept. You need to enjoy chocolate pastry. Nobody doesn't like to have a beautiful dinner with a beautiful lovers. You don't really doesn't want really to enjoy occasional feast with friends and family. So that's why the microfast here is the way to go, and is able to really tolerate and able to continue and to able to adhere as well. So the how to microfast, you have to a concept of short, frequent mini fasts, for example, 8 hours a day, while you are metabolically active and walking and doing your exercise and everything like that. You do it only 2 to 3 times per week. No healthy snacking. Nothing called. I'm always telling, please don't snack. Don't tell I'm having healthy snack. Whatever you are eating, you are spiking your insulin, blood sugar, spiking your insulin, and storing fat. Whatever it is, a little bit or not. So you need to achieve a basal level of insulin all the time. Don't really spikes on and off. Gentle, more flexible version of time-restricted feeding. The question is, what is the rationale of having this one? So aim to trigger metabolic benefits with less hunger, better adherence, because really prolonged fasting is not a kind of lifestyle you want to achieve forever. Otherwise, you'll not enjoy your life. So also have a lower risk of side effects. There's no sarcopenia there. And then here you will be metabolically flexible. You are going to teach your body how to switch between glucose as a fuel, burning as a fuel, and fat burning as a fuel. So more metabolic flexibility here. So microfast is similar to intermittent fast, reduction of insulin level. So body shifts from storing to burning fat. Calorie intake often drops naturally when eating window is shorter. Metabolic switch from glucose to fatty acid and ketones. So really, metabolic flexibility here is the secret behind the metabolic microfast. So microfast is magic because it improves metabolic flexibility. So better fat oxidation at rest and during activity without really strong hunger or social disruption. So easy on long term, easy to adhere on long term. So a better adherence, more consistent calorie deficit, also better fat loss. So the micro fast and muscle mass eating window is longer now, allow regular protein intake. Liver detox, easy to bear with resistant training. Boost metabolism, protect resting metabolic rate better. And strong relaxant, so long-term goal, fat loss plus muscle preservation. So it's really an easy way to adhere. An example of microfast and weight loss focus to fast for 8 hours a day. During the fasting time, extras allowed like water, coffee, black coffee, of course, and black tea. 16 to 12 hours without eating, around 12 hours here. Two balanced meals, and you should have here adequate protein during eating time. So you talk about 1.2 to 1.6 gram per kg per day if you're metabolically active and exercising. Also for concentrate on high fiber carbs, healthy fat, minimally processed food. This study has been published in the Obesity Journal, comparing intermittent fasting with protein basing versus calorie restriction with healthy lifestyle. I'm trying to convince you by this study because you need to increase the protein intake during the eating period. This study is strongly positive, and the first study to show that intermittent fasting is very superior to calorie restriction in a matter of weight loss and visceral fat loss. So better gut health, microbiota also in the study of 2024, the diversity of microbiome is better when you fast with protein basing, 33% more weight loss, and 50% more loss in the visceral abdominal fat and higher fat-free mass by 50%. And the secret behind that, protein pacing and high protein intake has a thermogenic effect as well as increasing metabolic flexibility during fasting. So how to make it possible is to get 25 to 50 gram protein during the eating period, and you distribute that kind of protein 25, 25, 50, 50 like that during the eating period is called the protein pacing. So take home message like the microfast is promising and practical because of metabolic flexibility. Is a shorter time of fast, easier to maintain, is offer benefits of improved metabolism and weight loss. The best approach to achieve consistent especially when combined with nutritious eating with 25 to 50 gram protein per meal, which is called protein pacing, and to strength with the strengthening training or strength exercise. Of course, more research is needed, and most of the study has been also enrolled a day of prolonged fasting. So you fast for 1 day a week, 24 hours fast, in addition to the rest of 2 to 3 days remaining to go with intermittent fasting. So you have to understand clearly that microfast and intermittent fast are not competing to each other, but must now be seen as a power couple in the new weight loss paradigm. I would like to finish my lecture with Siha, which is the strategy in my life. You need to sleep well, you need to manage your stress, you need to practice sex regularly, you need to exercise, you need to have concern about or concentrate on epigenetics rather than the genetics. So you need to switch on the good gene and switch off the bad gene. You need to have period of hunger with time restricted feeding, When you eat, you need to eat healthy diet, eat high protein, please, and distribute it between your meal, at least 25 to 50 gram protein per meal. Start with protein first because this effect is called secondary meal effect. So if you eat protein, you will spike a little bit the insulin. So when you eat carb afterward, the insulin will not spike that high, which can cause really harm and also inflammation and the fat storage. So here, eat protein first to prepare your beta cell of pancreas to release little insulin. When you eat carb, you not spike your insulin faster. This is called secondary meal effect. So also you need to have an adequate microbiome. Be sure you are getting healthy food, and also at the same time you are gaining probiotics supplementation at least 2 weeks per month. You need to get the deficient mineral and vitamins regularly. If you are deficient in mineral and vitamins, your body is mad. You want to eat anything just to you need to refill the minerals and vitamins. You don't know about that. When you start to take minerals and vitamins, you feel like really satiety and not hunger anymore. So eat in a way that's sustainable and long term. Don't really make like a super thing. Like no, do sustainable things and long term. All kinds of diet manipulate carbs. So you need to manipulate your carb. I believe you need to stop eating like rice, macaroni, and white bread. This is very, very dangerous for your health and can cause inflammation all the time. You need to understand what you eat will affect your health and thus your entire life. Again, like the words of the Albert Einstein, you have to know the role of the game and you can play it better than anyone else. And I'm always telling that knowledge is a power. The poorest people are the one who don't have time to learn. So we need really to learn every day. We are learning from each other on daily basis, and your future is created by what you do today, not tomorrow. I'm Khaled Swifi, and really thank you very much. And time for a question. Have a lovely evening.
Thank you. Amazing. As usual, mashallah. Beautiful, beautiful journey, صراحة. So we will take صحة and apply it all. There's questions for you actually. Will you, Mireille, ask the question if you don't?
Sure, of course.
There is 2 questions. I'll start one and Dr. Mireille will
Yeah.
take.
So one of them is it possible to manage obesity lifestyle attitude, medical treatment with sending for surgical interference bariatric surgery? Not sure if that question is clear.
No,
Of
there's
course,
one
I
from
like
Amina.
lifestyle modification is very, very important, whatever you are doing, bariatric or non-bariatric surgery. You cannot win without changing lifestyle. And as I mentioned, try to do things which you're able to do it on long term. So there is no doubt that lifestyle modification is number one. Even in the clinical trials of LGLB1, GIB, and all stuff, lifestyle is present in both arms.
I see. Amina is very active. Thank you, Amina, for all your valuable questions. It's for Dr. Khaled again. Should diabetic patient take rapid or long-acting insulin injection if they intend to fast for 12 hours, or should they not take the injection at all?
No, of course, diabetic patients, they should take treatment. And we have difference between type 2 diabetes and type 1 diabetes. So type 1 diabetes, when you talk about insulin here, you need really to go with a doctor when you're going to fast. He will tell you exactly, today I'm going to exercise and fast. You need to reduce really the long acting and consider short acting like that. If you are type 2 diabetes, you are not getting really insulin and getting oral anti-diabetics. Here you can improve really because type 2 diabetes is due to insulin resistance. So if you change your lifestyle, if you go to eat a healthy food, if you exercise, you fast, you really improve your insulin resistance, and later on you can able to reduce your medication, even to stop medication in the future.
True. Mireille, you'll take the other one?
Yes. And I wanted to comment on what Dr. Khaled said, do something that you like because it has to be sustainable. Sometimes people do treatments that feel like a prison and they're counting, like jail prisoners, they're counting the days, how many days they will still do that. So the minute you stop, you will gain back. So the idea is, as Dr. Khalid said, do something that you like and increase those behaviors until the new healthy behavior becomes part of you and not a punishment that you're counting the number of hours and days. There is a question. I'm not sure which one of us will answer, but let me read it first. In terms of food marketing and taxes on food security and schools, just wonder if any updates on this matter in the region, because it plays a big role in obesity management. Excellent question, Yasmin. I love that. I'm happy to respond, but I'm also happy to hear other people.
Okay, go on, Mal.
Yeah, I mean, I think one of the main things is ultra-processed food and the sedentary lifestyle, and the way that we teach our kids from very young age that birthday parties and happy moments are correlated with cake and chips. And, with the Pavlovian way, we condition their brain to start seeing, as food, as a comfort. We train our brains like that. We make sure all our kids, correlate their happy moments with sweetness, and then wonder why obesity is such a big issue. So yes, Yasmin, that is a big question. Unfortunately, taxation, in some countries,
but nothing done. Yeah.
Very few countries are being able to actually fight the food industry's taxation system and enforce it. But let's not lose hope. Cigarette worked out, so maybe ultra-processed foods will work out. So let's all fight. I mean, every effort for this is useful. Every one of us can.
We have one question from Adil. Adil is asking, first of all, he thanks both of you for the excellent presentation. And he's saying, from practical point of view and your experience in dealing with obesity, is it possible to manage obesity, lifestyle, attitude, medical treatment with sending for surgery interference and bariatric surgery?
Well, the same question we answered, I believe. Like lifestyle is
different.
Important. Yeah, important. Like going to surgery or not going to surgery, you need to change your lifestyle to a healthy lifestyle, which really you like and sustainable.
Actually, even with Dr. Khalid with bariatric surgery, again, 6 months you have to be on diet to make sure that you're gonna succeed in the bariatric, because after bariatric, a lot of things happen, right, Muna, Mireille? I think you have comments on that, because if you don't know what to eat after bariatric, even with bariatric, 44% they regain weight. So it have to be here.
And the losing muscle as well. So if you did not exercise,
it have to be here at the beginning. As Muna said, psychological effects, right, Muna?
That's absolutely correct. Yeah, I agree with you, Dr. Wafa. And just answering Adil, in case of lifestyle, changes and exercise did not help the patient to achieve his healthy body weight, a surgical intervention is recommended. But we cannot jump, to the surgical intervention as a first, attempt to lose weight. We start initially with building, the lifestyle changes, and if it didn't work, definitely we can go for surgical intervention while taking into consideration all of the aspects from a nutrient, vitamin supplementation, exercise, protein intake, just to make sure that the patient doesn't fall into, the negative, consequences of sarcopenia, of muscle loss, of, malnutrition after the surgery.
There's a question, and I think maybe Muna can answer. What about skipping meals? Is it healthy or not? And is it necessary to eat breakfast?
Okay, so when it comes, to the meal structure, from my point of view as a dietitian, I always, take each, condition as, as individualized. We need to understand the patient's preferences. We need to understand what is convenient for the patient. We need to understand the lifestyle of the patient, because at the end, one size do not fit, all of the cases. In case of skipping a breakfast for the patient, keeps giving him a good energy level, keeps his focus in a good way, keeps him, if the patient keeps, doing his physical exercise, it doesn't lead to binge eating in the night, this is a good option. But if skipping a breakfast or skipping a meal is leading to negative consequences, the patient, for example, will start to have hypoglycemia, he is skipping his exercise, he's unable to focus, this is leading to a constipation, it's giving him an additional, caloric intake throughout the day, we recommend not. So that's why we cannot generalize. We need to take each patient as one case, understand it, and find what's the best solution for the patients.
Yeah. Some people will love skipping a meal and eating 2 meals, and some people will benefit from 5 small meals. So
correct.
That is why individualized diet, not taking the advice that your friend got from their dietitian and use it for yourself. Probably it will not be good for you.
Or from the influencer.
Or from an influencer.
Yeah, the best thing really to, as you mentioned, to really to try by yourself. For example, me, what I'm doing, I'm exercising every other day. So the day I'm exercising, I'm eating breakfast, and day I'm not exercising, I'm not eating breakfast, I'm skipping the breakfast. So it is really there's not one size fit all, and not every day is the same. Like you should not take breakfast every day. If the time you are not really you are fasting or you like to fast, better to not to skip breakfast. But if you are exercising and active, better to take a breakfast.
Actually, that's why it's now precision nutrition. It's individualized, it's tailored. So
That's
this is the aim of not to fit all, because as Muna and yourself and Dr. Mireille said, it have to be tailored for them according to what their needs. Otherwise, actually, they will not comply. If I give them upon my decision, nobody will follow. They just take the paper or whatever I said. As soon as they go out, they will do whatever they want. Again, psychology plays a big role, as Muna said from the beginning. And you showed how we have so many ways of giving what they need in a proper way. So, as you said, taking breakfast, good exercise, that's a solution. Not having breakfast if you don't exercise, maybe it works with them. So, again, it depends on them. I don't think there is any other questions, but Saraha, I love the audience. They were amazing. Yes, me, thank you. Yes,
Wafa,
me.
there is one more question, and it's very interesting. Can pediatric adolescents also be allowed to practice fasting? Maybe Dr. Khalid can answer.
Oh, yeah, down. I didn't see it, so sorry. Yes.
I'm not sure really. Most of the study done above 18-year-old for intermittent fasting. But really, we need to also train them to have a period of not eating. So they should learn, same like learning how to eat healthy. They know really the time they have to not eat. Not every time they want to eat, they are going to eat and spike their insulin and making your brain worse. And then you talk about autism issue and ADHD. So it is applicable, but not really in scientific way, but just as a form of teaching them the good habits.
Isabel Barrier have a question also. I think it's at the end. When is the best time of the day? Do you suggest to fast for the result and
Yeah,
health benefits?
a good question, by the way, because really, as a study, we have a recent study done. The best kind of fasting is if you are going to have like early TRF or early time restricted feeding. So if you're going to fast from 3 o'clock, for example, to next day will be much better than you fast from 8 o'clock in the night to next day. So to fast during the time who are you metabolically active.
Okay.
Recently, I published something on that, and I would like to comment. The sooner you stop eating, basically, the better. A very common time frame for eating window is 11 a.m. to 7 p.m. That's most easily adapted. But we looked into all the other studies where people were imposed to have earlier eating window, and they didn't complain because they felt full, because they took the number of calories and they felt full. So they didn't complain if they started earlier and stopped earlier. So the sooner we stop eating during the day, whether it's intermittent fasting or not, is the right way to go. At least 4 hours before sleeping, no? At least.
Thank you.
I don't think we have more questions, Wafa.
No, but it was
I think
amazing
we addressed everything, yes.
evening and amazing speakers. Dr. Khalid, thank you. It was really good. It was super. Mona took us on a tour in a bias, and this is something, wallah, it was 100% with a beautiful moderator, Dr. Mireille Salaha.
Definitely, Wafa.
And you. And
Yeah,
you.
yeah. Honestly, I enjoyed every single minute. You agree, right, audience? I'm sure you did. So don't be delayed in registering for our. See the speakers. This is just a sample. Wait for the rest. It will be amazing. I am sure. It was an amazing evening, Dr. Mireille.
Thank you. Thank you for everyone. And I hope we see you in the fellowship because there will be more
Inshallah.
of this.
Yeah.
And Dr. Khalid, maybe we can announce because there will be another webinar in mid-January happening and another one in mid-February where we'll give you a little bit again the taste of the fellowship and what to come. And hope to see you there. Dr. Khalid's team will be able to announce and share with you the next dates, but it's somewhere around mid-January. So look for
Jan
the
12.
announcements.
Jan 12.
Inshallah.
January 12, yeah.
Inshallah. See, he gave you the date. So be
Yeah.
ready.
Be ready.
With the rocket he put, just be in that rocket. We will rock the obesity in the Arab world with
The
us.
best is yet to
Yes,
come.
Dr. Amr. Anyway, thank you. Have a beautiful evening, Dr. Muna, Dr. Khalid, Dr. Mireille. Thank you so much.
Thank you
Always
very
a
much.
pleasure.
Have a lovely
Have a
evening.
nice evening,
Bye-bye.
audience.
Bye-bye.
Take care. Bye-bye.